Hello, everyone. My name is Carmen Jackson, and this is my DMP scholarly project, and it's entitled Using the Numerical Rating Scale in Triage, a Pilot Study. Here are my committee members. I would like to thank my committee members, Dr. Rachel Davis, for her dedication and many hours, even after hours, of help on my project. Dr. Stormont, as my community chair, for his assistance in getting approval for my project at our place of employment. My supervising physician, Dr. Peter Roble, office management, other providers, nursing staff, and all who assisted in making my pilot study and scholarly project easy and successful. Lastly, I would like to thank Dr. Mark Pauls, the Maryville statistician, for his assistance, other Maryville faculty, the IRB, and my fellow peers at Maryville University for all of their support and guidance during my project. Patients present to urgent care and even emergency room departments with a wide range of complaints. Approximately 70% of urgent care visits are due to the complaint of pain. Pain is subjective and can often be underestimated or even overestimated by healthcare providers. The evaluation of pain is geared to provide care according to the need of each patient. Assessing patients' pain is the first step in providing proper care for pain relief. With the use of pain assessment tools, this ensures that the methodology is appropriate. Baha-Rudin and colleagues, 2010, states that pain is a complex area that is affected by physical, psychological, socio-demographic, and cultural factors. Their study revealed that assuming a patient's pain level can be inaccurate and thus can cause inappropriate treatment. This can be prevented with the use of pain assessment tools. Utilizing pain assessment tools will validate the patient's complaint of pain, and after treatment, the NRS can also be used to evaluate the effectiveness of any treatment that was provided. Literature review was conducted by searching numerical rating scale, pain assessment tools, and finally using the fifth vital sign. Several themes were revealed with the literature search. Pain is prevalent, lack of education, lack of time, and lack of invaluable pain assessment tools. The predominant theme was that pain is a prevalent issue for patients and providers. Booker and Her, 2015. Booth and Edrin and colleagues, 2015, reports that untreated pain can slow the healing process. Pain tools should fit the situation as well as the individual or population. Lack of education. Some providers may not judge patients' pain because they do not know the proper pain assessment tool to use for the individual. Christie and colleagues, 2018. Educating and training providers in pain assessment tools and their use can decrease patients' issues in unaddressed pain. And the goal of education in using the NRS is to reduce the improper treatment of pain and to validate standardized treatment plans. All of the education for pain assessment tools will be of no benefit if time is not taken to assess and address the complaint of pain. Christie and colleagues reports that prevalent in the research was that staff being overworked prevented proper pain assessment by using pain assessment tools. DeCastro and colleagues reports that many providers simply refuse or cannot take the time to assess pain sensitivity. With the lack of invaluable pain assessment tools, taking the time to utilize the proper pain assessment is invaluable to the appropriate management of pain. Christie and colleagues, 2018, states that along with time restraints, some researchers report that pain assessment tools are unknown, unavailable, and are insufficiently implemented, making them inadequate for proper information. With the literature search, several articles suggested that pain should be assessed as the fifth vital sign so it could be evaluated consistently and addressed if needed. Gaps in literature. The literature reviewed agreed that pain is a prevalent problem that should be addressed quickly. Baharudin and colleagues, 2010, reports there is a significant difference in patients' report of pain compared to the assumptions of pain sensitivity by nurses and providers. The study conducted by Gusty and colleagues, 2018, reports the gap between nurses' assumption of pain compared to patients' reported pain could be bridged with the proper use of pain assessment tools such as the numerical rating scale. Booker and Her, 2015, says that for pain assessment tools to be valid, they should be culturally diverse for different populations. There are several pain assessment tools available. Per Gregory and Richardson, 2014, unidimensional and multidimensional self-report tools are the most reliable measure of pain as long as the person in pain is listened to and believed. One such tool is the one represented here, the Wong-Baker Smiley Faces tool. This tool is used with your pediatric patients over the age of 3. The faces depict different expressions ranging from happy to extremely upset, and each face is assigned a number from 0, which is smiling, to 10, crying. The Visual Analog Scale, or VAS, is used to measure a characteristic or attitude that is believed to range across a continuum of values or symptoms. The Numerical Rating Scale, or NRS, is another example of a unidimensional self-report tool just like the Wong-Baker and the Visual Analog Scale tools. The NRS is the most commonly used pain assessment tool and is the topic of this presentation. This DNP scholarly project is entitled The Assessment of Pain Using the NRS in Triage at an Urgent Care Facility, a Pilot Study. The purpose of this scholarly project was to assess the compliance of using the numerical rating scale for pain assessment in triage at an urgent care facility. For this DMP scholarly project of consistently assessing the numerical rating scale in triage and timely management of pain, Betty Newman's system theory fits well. The system theory emphasizes stressors and their impact on the patient and states that stress reduction is the goal of the system model of nursing practice. Vanaki and Rafi, 2020. Vanaki and Rafi, 2020, reports that Newman's theory is appropriate for patients who suffer from chronic disease. Pain is complex and can present either acute or chronic. Baharudin and colleagues, 2010. Another theory that supports this project is Joyce Travelby's person-to-person relationship model. This model reports that the relationship between the nurse and patient can happen by showing concern. Utilizing the NRS consistently in triage to validate one's pain sensitivity and providing timely pain management will show concern. Travelby's theory includes the thought that providers help the patient and family cope with the experience of illness and suffering, and if possible, find meaning in such incidents. Morera and colleagues, 2018. Per the Centers for Medicare and Medicaid CMS guidelines, it states that providers should utilize pain assessment tools to assess patients' pain sensitivity. Pain, of course, is subjective, and the evaluation of pain is geared to provide care according to the needs of each patient. Working at a high-volume urgent care facility, assessment of pain and early intervention for pain management are major concerns. To address these concerns, a quality improvement project during a 5-week pilot study was conducted. This study was done to evaluate healthcare team members' compliance of using the NRS in triage before and after an educational intervention about the NRS, its importance, and its use. After the intervention, 100% compliance of using the NRS in triage was the expectation. Before this quality improvement scholarly project, the NRS was not consistently assessed in triage at this facility. This pilot project was conducted to determine the effectiveness of the quality improvement program designed to reduce patient discomfort timely. The specific aim for this project was to determine if implementing a pain assessment protocol in triage would assist providers in early assessment, intervention, and treatment of patients who present with the complaint of pain. And the overall aim was to assist in identifying early interventions for pain management and to ultimately increase patient satisfaction. For this DMP scholarly project, a quasi-experimental quantitative retrospective chart review was conducted. After receiving IRB approval, the NRS tool was placed on the triage form for the 5-week pilot study. Pain assessment is classified as the 5th vital sign, and it is critical in managing pain effectively. The retrospective chart review produced pre- and post-educational intervention data that was used to assess compliance rates of using the NRS in triage. Here is an example of one of the slides used during the educational intervention that was presented by me at the mandatory educational intervention. During the educational intervention, team members were advised that 100% compliance was the expectation for using the NRS in triage. For this quality improvement research study, a total of 296 charts were reviewed for the retrospective chart review. Pre-educational intervention charts totaled 150, and post-educational intervention charts totaled 146. Data collected revealed the statistical significance of increased compliance with the NRS assessment tool being used in triage after the educational intervention. Z-test statistic showed the p-value of 0.0000, which is less than the significance level of 0.05. Because of these findings, the null hypothesis was rejected, as shown in Table 1. Per Pollitt and Beck, 2017, quantitative research studies should collect meaningful, accurate, and valid data. This study had a large sample size, which increased the adequacy of the data. Pollitt and Beck also states that quantitative research is related to the positivist paradigm assumption. This is the scientific method of the study conducted to determine a hypothesis that can be tested in the real world. The information that is collected is quantifiable and objective. For the analysis of the results, the upper one-tailed z-test was used to analyze the data collected, and it also produced the difference of the two proportions. Discussion of limitations. This scholarly project has heterogeneity generalizability. This is represented in this study by including all genders, everyone spoke English, all aged 18 to 70 were included, and any patient that presented to the clinic during the 5-week pilot study was used. This sample is characteristic of the local population and thus decreases the chance of sampling bias. Pollitt and Beck, 2017 states, generalizability is a criterion used in quantitative studies to assess the extent to which findings can be applied to other groups and settings. Sustainability. Regarding sustainability, this project falls under health services and outcomes research. According to Pollitt and Beck, 2017, outcome study attempts to understand the results of healthcare practices and effectiveness of healthcare. With the increased compliance of assessing the NRS in triage and patients' complaints of pain being addressed early in treatment, the NRS assessment tool was permanently added to the triage form at my clinic. Minimizing limitations and effects. To minimize limitations or potential threats to validity of this study, specific participation characteristics were incorporated into the study. Randomization was utilized to acquire comparable groups for this quality improvement research study. Another aspect of reducing restrictions in this study was the large sample size, which increases statistical power. Heterogeneity, generalizability, as stated prior, was also utilized to minimize limitations for this study. And lastly, the limitation of this study was minimized by making the educational intervention mandatory for the entire healthcare team. This ensured the whole healthcare team was aware of the study, the purpose of the NRS, and the expectation of 100% compliance with its use. For implications for nursing practice as a result of this study, the NRS is permanently embedded on the triage form. This has enabled providers to have patients' pain assessed early and initiate treatment quickly, which in turn increases patient safety and satisfaction. For future research, it could include adding questions about pain sensitivity questions on the patient satisfaction surveys. The assessment of pain using the NRS in triage at an urgent care facility, a pilot study. Thank you for listening. Are there any questions? Here are my references.